But now I'm delighted to introduce Professor Anne-Marie Russell to speak on symptom management, particularly with respect to fatigue. Now, Anne-Marie holds a Jenny Jones Chair of Nursing Science and is Professor of Interstitial Lung Disease Supported Self-Management at the University of Birmingham. We're very lucky to have her today as she has literally just returned from a lengthy working trip to Australia. So before jet lag kicks in, I will hand over to her. Thank you, Anne-Marie.
Thank you, Graham. Just checking that you can hear me okay.
Loud and clear.
Wonderful. It's great when technology works, isn't it?
Yes.
Let me see if I can share my screen. Is that working?
Yes, it is. You just need to go into presentation mode. You're still seeing the slide sorter at the moment. Yes. There you go.
Wonderful. Thank you very much. And thank you very much for inviting me to join you today. I know it's a packed day and everyone's sitting at home. So I just really like to invite everyone to have a big stretch so that you're not getting a feeling that you're getting sitting disease. And hopefully I'll keep you engaged throughout this next little bit of time that I have with you. Thank you very much for that introduction. And yes, I arrived back in the UK just last Wednesday from a 2-month stint at the University of Adelaide, which has now been renamed Adelaide University, which is really interesting. But I hot-footed it to Frankfurt for the EU PFF meeting over the weekend, which again was a really dynamic, patient-centred meeting. And we may talk about that a little bit later. So these are my disclosures. And I wanted to start out by recognising, and these are professional colleagues, but some of the people that I have the privilege of working with, because I think both in clinical care and in clinical research, we support each other and bounce off each other and share ideas. And without working with this fantastic group of people, I would not be where I am today. But particularly of note is Karen Patterson and Obi and Leslie Sackett-Koo and my Elaine Drent. We've done quite a bit of work together in the field of sarcoidosis, and new to that element of my work is Chris Huntley, who I'm now working with in University of Birmingham NHS Health Trust in clinic every week. So yes, thank you to everyone that I have the pleasure of working with. So I'm based at the University of Birmingham, which is a traditional university. We have some important landmarks, such as the Clock Tower, or Joe, which is the tallest freestanding clock tower in the world, which is our claim to fame, I think. And we have a history of innovative research, such as the first artificial contraceptive pill, which has created an ease of living for many women throughout the world since. We are a vibrant campus with lots of new buildings, but I have to say I don't work in any of those. I work in this old building over here and in Chest Clinic in the old TB hospital in the centre of Birmingham. But I think it's safe to say it's what goes on in a building that is more important than its infrastructure. So I've been asked to talk today, and hopefully you're expecting this, about some of the symptoms of sarcoidosis, how we might manage these. And then I'm going to touch a little bit on digital health, because that's an important part of self-care and symptom management, and finish up with just a little bit on workability, depending on how we do with time. And from my background, it's very much in interstitial lung disease, so I do have a lung focus, but I'm mindful of the fact that some of you on the call may not have any lung manifestations of your sarcoidosis. And so just to say, I also have over 20 years experience of working as an advanced practitioner in general practice. So very much aware that bodies do not present as organs, but as complete bodies with organs that interrelate. And therefore, I'm very much committed to holistic assessment and health. But we can extrapolate a lot from the lungs to living with sarcoidosis. Am I going to provide you with all the answers? I would love to say yes, but quite possibly not. I think it was Thomas Edison that said genius is 99% perspiration and 1% inspiration. So I fear I'm very much at the perspiration stage of life, and I seem to have been here a long time. Although I may feel inspired, it takes a lot of work to get research through to clinical practice. But what I would say is part of that is about working together as patients, as providers of healthcare, alongside the pharmaceutical agency and policy makers, because unless we all come together, we're not going to affect meaningful change and improve our healthcare services and our individual well-being. So within that vein, I would say that for most of my research, patients are very much co-producers of the research, and I hope it feels the same in the healthcare provision and policy and practice. So as a patient navigating the system, very much aware that there are lots of stakeholders, the patient being at the centre of this, and a number of providers. And sometimes that can be a good thing, but sometimes it can be quite challenging when you're trying to navigate your way through. And I guess the person that is consistent throughout whatever the healthcare context is the patient. And so for us as clinicians, working together is really important because you are the experts of living with your disease. And it's only through really understanding your experiences that we can identify the important research questions and look at effective symptom management. So you're very much, to me, a valuable resource, both clinically and in clinical research. And so I guess it's that joint working that enables us to improve the quality and the safety if we're using person-centred or people-centred approaches in our healthcare. And part of that is this transition to the digital first approach, which has arrived with us kind of surreptitiously, although we kind of expected it and it's kind of been there, but it's gradually taking over. And the future will very much become increasingly digital for lots of different reasons. One, we have a shortage of doctors and nurses, and we have to look at innovative ways of working. But also the technology can provide an easefulness to some certain aspects of care, provided that it complements traditional healthcare models as well, and that people don't feel abandoned and left to self-manage alone. And I know that many of you in this room will really struggle with getting appointments with your GP. And so the thought of the GP and primary care being the hub of this digital approach to healthcare is probably quite anxiety provoking. But I think we've got a big investment now in some community centres and diagnostic centres that can maybe go beyond that diagnosis, but look at providing comprehensive services around symptoms such as breathlessness. And in terms of these innovations, at the University of Birmingham, we're doing some joint work with primary care and with our computer scientists to look at innovative approaches. And there's some fantastic work coming out of Bristol as well, led by Giles Dixon, that is looking at the use of the stethoscope for patients who are community-based, so that in addition to the traditional telephone consultation, you listen to lung sounds as well. So used wisely and used with good support, I think digital approaches offer a lot. But there are some concerns, and I just wanted to flag this lovely survey that came out of New Zealand that looked at patients' perceptions on digital health tools, and this is generically across a patient group. And certainly it can be empowering, it can feel personalised, it can feel like a patient-driven solution. But barriers do persist, particularly around digital literacy and health literacy. And there's also concerns around privacy, although we do have GDPR. There's been a few hacks into health records, and sometimes we do get misrepresentations from hackers. So there's a lot that we need to do still around privacy and data sharing agreements with companies that host these large data sets. And so some of you may be familiar with the Good Things Foundation. They do some really nice patient-centered work. And I guess for everyone, and that's probably everyone here because you're in the group and you've signed up to the webinar, is that you're digitally literate. But there are lots of people who aren't with us today who are the other significant percentage of the population who feel a little bit left behind. And that is not necessarily just around schools and education, which is something we can do something about, but it's also for those living in rural communities, such as myself, who really suffer with Wi-Fi access and limited download and upload data plans, which interfere with communication. And so we have to go cautiously. We have to identify those patients who are struggling with their digital skill set and digital access, and have a hybrid approach, move towards these different ways of working. So from an interstitial lung disease perspective and thinking about lung manifestations, sarcoidosis sits there as a major interstitial lung disease, and alongside connective tissue disease related interstitial lung disease and idiopathic pulmonary fibrosis, sarcoidosis is one of the most common fibrotic lung diseases that we come across. And so it's very much a significant part of our work, particularly in our clinic in Birmingham. And so the clinical management of interstitial lung disease, the MDT team has kind of very much evolved to embrace all aspects of interstitial lung disease. And this is a diagram that I use a lot, but when I put this slide in for this talk, it really made me think about the people who are missing for individuals with sarcoidosis who have multisystem disorder, and thinking about how we can kind of coordinate and communicate care. Where it is efficient, a patient will leave a clinic appointment with a copy of their clinical letter in their hand, which makes it easier going to the next appointment, but that is rare. And so thinking about who coordinates, who is the liaison between all these services that many of you will have experience of needing to access. And so one way we can do this is collecting and sharing on healthcare records patient-reported measures that capture that subjective experience of symptoms. And unless we're collecting these data, then we can't measure it. But it's also something that can be very useful for you, and some of you will use this method to monitor your symptoms over time. And we do know that from this subjective data, we can get very good objective measures that help us to look at improving health outcomes and experience. And I guess the other thing is, particularly for people with sarcoidosis, is that you often appear healthy, but it's those subtle symptoms. And if we're doing regular monitoring of symptom change over time, we can possibly acceleration of disease state. And so there are different ways of measuring patient report, and all these measures sit under the label of clinical outcomes assessment. And you can see here it may be performance related, so it may be around clinical data such as a 6-minute walk test or pulmonary function testing. But most commonly, and the thing I'm referring to here, are the patient-reported outcome measures that are collecting data about health-related quality of life, about feelings and perceptions, and about symptom experience and physical functioning. And that's a very much an important part of biomarker data as well, in terms of following the clinical course of the disease state. And the other thing that patient-reported measures help us do is initiate a conversation. So when we're sitting together in clinic, we all have unconscious bias, and you will be looking at the image of these two people and already formulating unconsciously some opinions about them both. And so we are sensitive to that, but not immune from often making misperceptions. And having a patient-reported measure that we can look at can inform the discussion and dispel some of those unconscious biases that creep into the consultation, and certainly help with the monitoring of the disease, and also help with diagnosis as well. So I just wanted to mention, in addition to the patient-reported outcome measures, patient engagement and patient activation, which is particularly important in this arena when we're thinking about supported self-management approaches and what is right for you as a person. And it's about helping individuals to understand their role in the healthcare process and identify where you are at with your knowledge and skills and confidence to manage certain aspects of your health. And then that helps to tailor interventions that are specifically aimed at improving your situation. And so this is a patient activation measure that is often used in a general practice session. And I'm not sure how relevant and how appropriate it is in interstitial lung disease. I did do some work using this. More than anything, I think it was an opportunity to open up discussions, particularly around when we don't know what causes a disease, and we don't always know how medication works, particularly in relation to antifibrotics. But I think it's a useful tool for you as a patient to reflect on and think about where you are at in terms of your knowledge, skills, and confidence in managing the sarcoidosis element of the life that you're living. So when we're thinking about managing sarcoidosis, obviously we rely often on pharmacological interventions, and this might be immunomodulation, and you'll have talked a little bit about that this morning, often steroid therapy. And then we may move on to things like methotrexate, azathioprine, infliximab, etc. And if there is lung involvement, then we may also be thinking about adding in antifibrotic agents such as nintedanib. But what is common to all interstitial lung diseases and often shared symptoms across these different diseases is taking a non-pharmacological approach to treatment. So thinking about psychosocial support, thinking about things like smoking cessation and access to rehabilitation, and palliation of symptoms, and then for people with progressive disease, thinking about those transitions to end-of-life care. And regular review helps to shape those non-pharmacological approaches depending on where the disease state is, whether it's stable, in remission, whether we're looking at prevention, or whether it is a disease progression pathway. And you don't need me to tell you because you live some of these symptoms, but certainly there are a great many symptoms associated with living with sarcoidosis. Some of those could be organ related. So for example, pulmonary symptoms may result in chest pain, breathlessness and cough, which can reduce exercise capacity. And there may be some extra pulmonary symptoms associated with that, which are listed here. And then there are non-organ related symptoms. So regardless of how sarcoidosis is impacting your organs, you may experience fatigue or pain, cognitive impairments such as memory problems and impacted concentration, sleeping difficulty, fluctuation in weight, loss of appetite, vitamin D deficiency, and everything that goes with that, particularly tiredness and fatigue, can be a concern. And then, of course, there are a host of symptoms associated with small fibre neuropathy, which I suspect you have covered this morning, so I won't go into those in depth again. So the burden of these non-organ related symptoms has been reported on in Lung in 2019, looking at comparing 3 countries, Denmark, Germany and the Netherlands. And you can see here that pretty much across the board, fatigue is the worst non-organ related symptom, closely linked with energy. And the difference in semantics between fatigue and impacted energy is quite difficult to unpick, and sometimes it can feel like the same experience. And then again, pain, and then sleeping problems, concentration and memory loss are the other symptoms coming after those. So how does this impact on quality of life? So it's going to have a negative impact potentially, and with that reduced quality of life, there can be some psychological distress around adaptation to disease and disease state as that progresses, which can give rise to some physical deconditioning. If you're off work, it can result in financial loss, or you can feel that having had to reduce working hours, you're not quite as involved in the decision-making processes as you were before. And all these things can give rise to feelings of depression, stress and anxiety. Sometimes that's a clinical depression, but it might often just be an altered mood, as well as tiredness and cognitive impairment. And so health-related quality of life in sarcoidosis is really important. And I just wanted to flag this paper that I know Sarcoidosis UK endorsed, but I think it's been quite a useful review prior to our paper on workability for some patients to take to their clinicians to get them to understand some of the nuances and some of the challenges of living with sarcoidosis. And so we identified certain factors that can improve health-related quality of life, and conversely, symptoms that can make health-related quality of life worse. And having access to good healthcare and good clinician communication are exceedingly important to make us feel better, alongside the appropriate pharmacological treatment, which may change over time. Having a program of physical training and exercise with appropriate digital support and a treatment package to ameliorate that feeling of disability and symptom burden, improve health-related quality of life, as well as these other factors. And I think those that reduce the health-related quality of life, it's not rocket science, will be familiar to all of you. But again, it's poor clinician communication and that uncertainty, and how we manage that uncertainty that can severely impact health-related quality of life. So there is a quality of life tool developed by the WHO, and if we look at a comparator between sarcoidosis and idiopathic pulmonary fibrosis with healthy controls, we can see that in people with sarcoidosis, the symptom burden is much greater than that with idiopathic pulmonary fibrosis, for all of these domains, for physical health, for psychological well-being, and concomitantly social relationships and environmental interactions. And so I think we really do need to shine the spotlight on thinking about how we support people to feel better in living with sarcoidosis. I seem to have a stuck key. So feel your quality of life might not be that great. And having some disabling symptoms is going to make you want to move less and reduce possibly the physical activities that you would do on a day-to-day basis. And this can slowly lead to a general deconditioning and a further reduction in quality of life. And so it's that revolving door that one can get stuck in. You don't feel great, so you reduce your activity. Your activity is reduced, so you're seeing fewer people. That may give rise to depression. Reduced exercise capacity can make you feel breathless, can give rise to greater anxiety and fear. And then you can start to feel out of control, and that loss of not being in control has a huge psychological impact. And then that loss of exercise capacity can reduce the muscle strength and also respiratory functioning. So breaking this cycle is really important. So thinking about some causes and risk factors for fatigue that is associated with sarcoidosis, which can be a primary driver for that reduced health-related quality of life. As you know from living with this condition, it is really poorly understood, and it's multifactorial, so it's often really difficult to unpick what's going on. We know that active inflammation and the release of cytokines alongside psychological impairment and altered sleep patterns all contribute alongside small fibre neuropathy. Diagnosing sarcoidosis-associated fatigue is really, really important because it can often be dismissed, and an extensive evaluation is essential because identifying that feeling of fatigue is a step to identifying some modalities that may help to ameliorate that experience. And we do know that although fatigue can sometimes be a consequence of the treatment itself, that even off treatment fatigue exists. So it may be that there are two different types of fatigue within that. So how do we measure fatigue? There are a few scales out there. The fatigue assessment scale has been validated for use with people with sarcoidosis, and so it's probably one that is favoured. And it's a brief questionnaire that just asks in a 5-point Likert scale how you are experiencing fatigue. So it asks a little bit about tiredness and about activity levels, and then both the physical and the psychological components of what it's like having fatigue. And this is readily available, and it's something that you could do yourself, possibly even on a monthly basis. Because when you're living with a condition, you adjust and adapt, and you sometimes zone out of how you're feeling. And it's often your family members or those that you live with who are the better judge of how you're performing. And so sometimes filling in a brief questionnaire, if you're feeling fatigue, can help you see over time that it's either got better or it's got worse. And if it's got worse, which are the domains it's got worse in, and then start to think about how we can maybe think of some activities that would ameliorate that particular element of fatigue. So in terms of treatment options for sarcoidosis, the drugs aren't always necessary for everybody, although in some cases they're essential. But there needs to be a strong emphasis on non-pharmacological support and symptom palliation. So I'm talking about symptom palliation a lot, so which means symptom relief, and I'm not talking about palliative care in the context of end-of-life care. So palliation of symptoms really important here, and really good to have that distinction that it is not end-of-life care, it is about symptom relief. But ultimately, you having the right information at the right time and in the right place to make informed and shared decisions is really crucial to maximise your own quality of life. So both non-pharmacological and pharmacological treatment options for the non-organ specific manifestations of sarcoidosis are listed here. We're going to focus on those non-pharmacological treatments. So there is emerging evidence around the use of pulmonary rehabilitation programs and cardiac rehabilitation programs for those with pulmonary involvement. Different forms of physical therapy, which could include physiotherapy or aquatic exercise-based programs, can help with improving fatigue and cognitive dysfunction. You'll have talked this morning about small fibre neuropathy, and again, psychological support and possibly the use of mindfulness are ways to manage some of those manifestations of pain, as well as support group participation, which you're all converted to. And then in terms of depression and anxiety, thinking about specialist comprehensive pain management and ensuring that sleep is appropriately assessed and treated. And sleeping problems sometimes can be alleviated with the use of CPAP. And for all those other elements, generally exercise that feels comfortable is good for all of us. It may be a formal rehabilitation program, or it may be just counting our steps, alongside having access to counselling and peer support. And there is increasing evidence around mindfulness-based therapy, but unfortunately, a lot of those studies are quite small. And so for the most part, these interventions are unfunded. And of course, for some people, supplemental oxygen and ambulatory oxygen may be necessary. And so in terms of thinking about that palliation of symptoms, there's this lovely review that was in Lancet Respiratory Medicine, and the Lancet seemed quite committed to alleviating the abyss in palliative care and for pain relief as well. And so this review, which was 2017, I think, focused very much on optimising palliation of symptoms and thinking about patient-centred management and caregiver support, as well as symptom-centred approaches. And I just wanted to highlight that we've just launched the Weight of Air, which is a commission on palliative care integration in serious respiratory illness. And this will include some patients who are living with sarcoidosis, or caregivers of people who are living with sarcoidosis. So myself and Kathy Lindell and Smitri Rana from Pallium India are the commissioners for the patient and caregiver voice. And so it may be that I'm reaching out to Sarcoidosis UK to do some work with you as we move forward. So the serious respiratory illness is interstitial lung disease and COPD and pulmonary hypertension. And there's a strong focus on looking at those who are experiencing socioeconomic deprivation to look at improving our palliative care offering and find absolutely what is needed. So we're now in spring. I left the autumn in Australia. Aging for all of us is a natural progression, whether we like it or not. It happens. And the same with illness as well. Illnesses progress, sometimes they regress. But on that progression, we are going to feel differently with the passage of time. And Karen Pattison's published a really nice paper that's looked at interstitial lung disease as a function of aging. And as you can see here, looking at the age of onset, conditions such as idiopathic pulmonary fibrosis are associated with senescence, with the aging process. Sarcoidosis, less so, tends to affect younger people, though that it doesn't necessarily exclude some of the elder population. And regardless of where you are, maybe you're in remission, we do know that we're all living a longer life for the most part, which is a good thing. And that for most of us, that extended life expectancy is going to be disease-free. So for sarcoidosis, if you had that when you were younger and it's burnt out, that's a hugely positive thing. But focusing on that sustainability of well-being rather than illness, certainly we're going to be increasingly reliant on digital interventions. And that's going to be different for different people. We all want to be the best that we can be within the context that we've been given or that we can shape, accounting for our individual genetics and our environments. And we as clinicians have to recognise that living well has different meanings for different people. So I wanted to like this that we wrote on aging and frailty, and it very much recognised that frailty, the status of being frail, is very much associated with any age. We can be at high risk of being frail as we get older, particularly if we have underlying conditions. But someone with sarcoidosis in their 30s could equally feel frail. And that's something that we need to be thinking of measuring and something that we need to be sensitive to discussing. We are doing a little bit of work around developing a tool, but prevention of frailty is important. And again, collecting those data on symptom measures can help to predict progression of disease state and where the individual is. And frailty is important because, again, like that deconditioning cycle we discussed earlier, this cycle of frailty has been around a long time, but it's never really been bettered. But whether we're aging or whether we have frank manifestations of disease, there's a risk of developing a loss of muscle mass, sarcopenia, and that results in a loss of strength and power. It can reduce our mobility, and then it reduces our total energy expenditure, and then we feel like eating less, and then we can become undernourished. So this is really important to think about stopping that progression, that cycle of frailty. And again, taking those holistic approaches is important here. So I'm cognizant of time, and I think I'm probably going to wrap up since we've got some time for discussion. But thinking of what we talked about before in how do you manage your symptoms and how do you support yourself to self-manage at home so that you're using your clinician time wisely, because clinician time has grossly reduced. And there are a lot of benefits to the digital revolution and man and the machine, which can be empowering. And I think we're at this stage of consideration and challenges. How are we using artificial intelligence? How's that going to help us with symptom management and navigating healthcare? There's a lot of costs that we consider as well, thinking about scalability and some ethical and safety concerns. But we're very much in that space of using electronic health. A lot of the patient-reported measures are available electronically. We're using telehealth approaches, and that may be a way to overcome some of the challenges that we've had around access. And as I said, if we just look at this triangle, as people are living with long-term conditions and the number of professionals available diminishes, we are going to have to look at increasing the approaches to self-care. So it wasn't really the purpose of this talk, and I just flagged up some studies that were ongoing using digital technologies to look at improving exercise performance and fatigue. But I'm just going to flick through those. Some of them were using Fitbits, and there was the Sarc Online program in the Netherlands, and I'm very happy for everyone to have a copy of these slides. I didn't really want to dwell on this any more than necessary. But I guess overall, a lot of what these studies show is that the feasibility is there. These devices are usable. There is a dropout rate, but a lot of it is around feasibility. And so we do maybe need to think about the next stages to how we roll out some of these studies, but there's lots of promising baseline data there. So I'm just going to skip through those. And the telerehabilitation as well is another approach. So I'm just going to end by saying we've done a lot of work across interstitial lung disease, including some people with sarcoidosis with lung involvement. And the qualitative element is equally important, learning about experiences of the positives and the negatives so that we can tailor these approaches to support people in the right way. And the lovely Jessica Mandija is doing some work around the FAB service, fatigue and breathlessness in interstitial lung disease, which is in its early stages. But I think that is a kind of tailor-made adapted pulmonary rehabilitation or a complementary program to pulmonary rehabilitation, which may have a lot of utility for everybody. So we have to look after ourselves. A plant in the desert will persist, but if it's watered, it will thrive. So we have to pay attention to our quality of life. We have to ensure that the quality of our research is robust so that it positively impacts the quality of the care. And the other thing that is really important is the quality of decisions that are made. Just a last shout out for the Workability paper that SarcoidosisUK supported. And again, it was reminding assessors of disability to think about ability and to look at modified ways of how we work. There's a lot of work to do there. But I would suggest that you have a look at this paper if you haven't done already. And if you have problems accessing it, let me know and I can share it with you. But it really just identifies some of the obstacles that people living with sarcoidosis face when they're having to go through the worker assessment or disability, as it's called, assessment process. And to think about how we need to move to a much more holistic approach that is a shared decision approach that is right for you so that you have the ability to stay at work as long as it's suitable and acceptable. I just want to thank some patients as partners in research. Some of these faces are familiar to you that have helped me over the years and ensure that my work remains patient-centred. Thank you very much for your attention.
Thank you very much. There's a certain irony when you mention fitness trackers that my Apple Watch has shouted at me 5 times this morning for not leaving my desk. So I'll make up with that later, perhaps. We've got time for a couple of questions. In fact, I'd like to sneak one in, which has come up during the course of your presentation, in fact. And you mentioned remission and stability. And someone's asked, how do you define the difference between stable, remission, and burnout? How would you answer that?
So I guess from a symptom perspective measure using patient-reported measures, I guess at the early stage of the disease, it's having a baseline of what is right for that patient, so you know essentially what your score is. Some of these have what is known as a minimally important clinical difference attached to them. But sometimes the context in which that minimally important clinical difference has been established might be in a trial population rather than a clinical population. So that's something that we can be mindful of, but it may need to be interpreted in the context of the individual. So outside of research, thinking about serial measurement of fatigue, if we know what your norm is, alongside the other clinical biomarkers, we can look at your score over time, and some of the questionnaires can be predictive of disease progression and align well. From my work, mainly I've used FVC as a parallel marker. So the sooner you start collecting some of these, the metrics is the most important thing. I think it's also gives credence to how you feel, because we all know our own bodies. And sometimes, for example, FVC is not a fantastic marker always for progression. The DRCO is often more relevant, but not so easy to measure. So if you've got declining symptom scores on your sheets, but your FVC is staying stable, how you feel might be the flag to bring you into hospital to do some more detailed pulmonary function tests, and then highlight that there's been an exacerbation or a flare or progression of disease.
Okay. And a last question for you, because I'm time. So a patient struggling with fatigue with both cardiac and pulmonary sarcoidosis, they're on a 10 milligram steroid dose, but their question is, could the fatigue be down to the disease or the treatment?
Oh gosh.
That's just a
Yeah,
short question.
I think that's really hard to unpick. I mean, steroid treatment affects people differently. For some people, it can make them feel a bit manic. For others, it can be a bit more of a depressant. I think that if that dose of steroids is keeping the person stable, then it may be that there's no choice but to continue that pharmacological treatment. Then working out if that's contributing to the fatigue or not, I think is really, really hard. But if fatigue is a real symptom, it would be, again, looking at measuring that over time and looking at interventions such as good exercise, and maybe access to other structured programs such as fatigue and breathlessness that could help ameliorate that fatigue. I guess cautiously one might do a trial of steroids or a bit of a titration down on dose, but that would need to be done fairly carefully. And I guess if that then kept the disease state stable and the fatigue improved, then maybe maintenance on a lower dose of steroids would be appropriate.
Okay. Well, thank you very much. And thank you for making it back from Australia for us. So very good to see you.
Thank you for having me.